This video will focus on high output shock, also known as distributive shock. High output or distributive shock includes septic shock, neurogenic shock, and anaphylactic shock. Septic shock is a state of persistent hypotension with adequate volume resuscitation, resulting from a dysregulated host response to infection. Sepsis criteria include a documented or suspected infection and signs of systemic inflammation. These signs cover general, inflammatory, hemodynamic, and tissue perfusion parameters. General parameters include fever or hypothermia, tachycardia, tachypnea, altered mental state, significant edema, and hyperglycemia. Inflammatory parameters include leukocytosis or leukopenia, and elevated CRP or procalcitonin. Hemodynamic parameters include arterial hypotension and elevated mixed venous oxygen saturation or cardiac index. Tissue perfusion parameters include decreased capillary refill, along with organ dysfunction and failure. Organ failure can be diagnosed using the Multiple Organ Dysfunction Score, or MODAYS. Septic shock is typically initiated by bacteria, viruses, or fungi. The organism's cell walls release inflammatory mediators, increasing vascular permeability and vasodilation, ultimately leading to shock. Clinical features of septic shock align with the criteria for sepsis. Key signs include symptoms of inadequate tissue perfusion, high cardiac output, and reduced systemic vascular resistance if no hypovolemia is present. Management guidelines for septic shock involve oxygen therapy, nutritional and emotional support, vasopressors, ionotropes, corticosteroids, antibiotics, and fluids. Neurogenic shock results from spinal cord damage, usually at or above the T6 level. The injury disrupts sympathetic innervation, causing vasodilation and bradycardia. Clinical features of neurogenic shock include lower body paralysis, severe hypotension, bradycardia, warm skin, and hypothermia. Management for neurogenic shock includes oxygen therapy, cautious fluid resuscitation for relative hypovolemia, vasoconstrictors for persistent hypotension, anticholinergic agents for bradycardia, and warming. Anaphylactic shock occurs when a sensitized individual is exposed to an antigen. This triggers a type 1 immune response, mast cell degranulation, and the release of vasoactive substances like histamine. Clinical features include vasodilation, hypotension, increased vascular permeability, bronchospasm, myocardial depression, urticaria, and breathing difficulties. Treatment for anaphylactic shock involves stopping antigen exposure, ensuring oxygenation, administering adrenaline followed by fluid resuscitation, corticosteroids, and antihistamine agents.